And now it's my great pleasure to present our next speaker, Dr. Rahman Bizri. Dr. Bizri, you are with us, and okay. Dr. Bizri is internal medicine and infectious disease specialist at the American University of Beirut. Sorry. So Dr. Bizri is internal medicine and infectious disease specialist at the American University of Beirut. He's founding member and affiliate of the Conflict Medicine Program, Global Health Institute, American University of Beirut. Welcome, Dr. Bizri. Dr. Bizri will be talking about the changing and challenging epidemiology of viral hepatitis in Lebanon. You're welcome, and we are waiting for you, Dr. Bizri. The floor is yours.
You're muted, Dr. Bizri.
Okay. All right. Now you can hear me?
Yes, and please.
Yes, please. Thank you. So thank you for having this meeting. I'm speaking from Saida. We're 5 kilometers south of Saida now. Yeah, this was happening yesterday, and this is still happening today. So despite that, we are still carrying on with this meeting. This is a good representation of the ability of the Lebanese people to keep on doing what they should do, really, to be resilient. And this is an example of our resistance against further enemy aggression. I was asked to talk about the challenging and changing epidemiology of hepatitis A. We know that A represents one of the well-known 5 unrelated viruses that cause viral hepatitis. A and E together are responsible for the enterically transmitted viral hepatitis. However, the disease is usually acute and self-limiting, yet in certain circumstances, it can be a serious and debilitating illness. It is a global viral distribution.
Sorry, Dr. Bizri, for interruption. Dr. Bizri, sorry for interruption. Can you please put your screen full screen?
Yes, sure.
Thank you.
Okay. It has global distribution. However, it is mainly a disease of the developing world, of poor countries rather than of the rich countries that have already committed themselves to extensive immunization program and adequate sanitary infrastructure. The spread is oral fecal, and it is why we probably, when we talk about foodborne diseases and the waterborne diseases, maybe, this is where epidemics can happen when we have contamination of the source. This is why Lebanon has been experiencing repeated epidemics of this virus. Despite the fact that it's an RNA virus, yet it's quite a resilient virus in the environment. It can survive several hours on our hand, several days on food, and given the proper circumstances, it can survive for several weeks. In younger people, it's usually the disease is either asymptomatic or typically presenting any acute viral illness. However, in all children, adolescent, adults, and people above 50, the disease is more symptomatic, more severe, and the range of the illness can really be as mild as an inflammatory disease with jaundice, severe weakness, debilitation, and quite a protracted illness, to acute liver failure in all individuals. Fulminant disease occurs in less than 1% of people. However, in people above 50 and those who have underlying liver illnesses, it can, especially co-infection with other viral hepatitis agents, it can really be quite severe. Yet the disease has also extrahepatic manifestations, and complications can occur, especially in the elderly population, mainly with static hepatitis, relapsing or recrudescent hepatitis, where we can have it once or more, but it usually resolves finally, despite the fact that it can also cause severe liver injury. And of course, it can trigger an autoimmune hepatitis. The clinical course of the illness is, as I said, varies with age. It can protract in older people up to 4 even to 8 weeks of illness, sometimes even more. However, in younger people, it's usually milder. What we care about is this one. When we have usually the high elevation of the transaminases and the apparent illness, this is where probably the viral shedding in stools, where the contamination and transmission happen, becomes minimal. So this is why it's useless usually to isolate those people, because by the time they present for their symptoms, their isolation, their excretion of the virus becomes minimal, and most of the people who have been exposed before have really been exposed to the illness before the illness is more clinically apparent. Let's talk about the hepatitis A virus and the situation in Lebanon. Lebanon, because we said that this is a disease of the poor countries, let's see what's happening now in Lebanon. Lebanon has been declassified by the World Bank from a high middle income country to low middle income country. So now we are probably in a more red zone area. We have failure of our sanitary infrastructure as manifested by several outbreaks related to food and waterborne diseases, mainly to waterborne diseases, such as cholera that Dr. Matar has alluded to, hepatitis A virus, and I will show you, and other diarrheal illnesses, including dysentery and salmonella. We had really witnessed significant change in the epidemiology of HIV. Post the Lebanese Civil War, we had the Taif Accord, we had significant investment in our infrastructure. This significant investment in our infrastructure has led probably to improvement in sanitation for some time. We had also HIV vaccines being introduced to the country, albeit at the level of the private sector, where the private sector is believed to used to vaccinate around 50% of the population. So we have now a partial immunization status in the country. And we had started to witness decrease in the seroprevalence among younger age group. And we know that the disease, if it affects people at a younger age group, it's going to be less symptomatic and will not probably have significant clinical illness. We had another factor coming later, where plus definitely wars and so on, and the economic situation in the country. We had the Syrian refugees, where we are the country with the highest number of refugees per capita, and this is why we had several outbreaks related to the Syrian presence in Lebanon, including leishmania and other diseases. This probably put extra burden on the healthcare system, mainly the sanitary infrastructure, coupled with what you call lack of electricity, lack of water, and so on. So the problem becomes much more complex. To see what happened with the profile, changing seroprevalence profile in the country, we have this study from Dr. Milham, where this study was conducted somewhere before 2015, early these days, where we showed that people at 30 years of age, there is risk 40% of acquiring the disease. And this is significantly very high because these people are usually symptomatic. They are usually functioning people, either going to universities or going to work. And if you look at the profile of people still 30 to 40 years of age, there is a risk of somewhere around 25% of acquiring the disease. So this is why the author of this paper recommended the introduction of hepatitis A vaccine to the country at the national level. However, if you look to the work done by our group, we have really compared what late Dr. Shamma'a have done, and we have looked at the prevalence there. In people who are less than 12 years of age, the seroprevalence was around 80%. So at the earlier days, many people really had what you call high level of antibodies at younger age group, where the disease is less manifested clinically. If you look at the data done by me and Dr. Sharafi, you would see that people at university age or at high school age had around 60% seroprevalence, so 40% are also susceptible to develop symptomatic clinical disease. And this is what people anticipated has happened. So we have the first hepatitis A outbreak in recent times in Lebanon, where we have exceeded 2,600 cases or more. Given the fact that many people may not have reported the illness and so on, but this is quite significant, and this is data from the epidemiologic surveillance unit at the Ministry of Public Health. And now we are witnessing probably the second outbreak, where we are going to see more cases, and we are going to witness more cases coming. So far, we have exceeded this year, 2024, we have exceeded 1,600 cases, and probably we're going to see more. Yet we know that there is a gap here between 2021 and 2024. They are not yet haven't been reported. And if you, so this is the second outbreak we are looking at, and it's probably started earlier here, and it's increasing, and it will stay with us as long as the situation is so complex and we cannot do anything about it. And this is data published about 2022. I don't know exactly the source of the information given by the author, but if you look at this data published from Lebanon by 2022, although most of them are probably people, I don't know from where they did the data, but it's interesting to see that most of the cases that were reported were really at a higher age, at people where symptomatic disease is going to be, especially here, going to be significant. So if you look at this data from Muhafaza and from regions, you will find that the north of Lebanon and Bekaa are the regions with most cases reported in the first outbreak and in the second outbreak. What probably makes the north and the Bekaa more susceptible to these cases, first of all, they are closer to the Syrian border. They have the highest number of Syrian displaced people residing in our country, and more significantly, probably they have less developed infrastructure as compared to Mount Lebanon or Beirut or even some parts of South Lebanon. So this is why we probably have seen more cases coming from here. So Bekaa and North are the people who have really experienced, the regions who have really experienced the first cases of and the most severe cases in the and increased number in the first outbreaks, and they are at the same as expected are going to witness the significant increase in the cases in the second outbreak. We're waiting for data from 2022, 2023 to complete these graphs. And if you look at the number of cases reported by age, you would see that there is a significant number of people also affected age 20 and above. This is in the dark blue, and you can see that this is where we expect also severe clinical disease. So here, around 1,123 cases were reported this year alone in people who are 10 years and above. So we know that older children, adolescents, adults, and people above 50 will have more overt clinical disease, and they will probably, the disease will have more burden on the population. So before we move into Lebanon, just a reminder that since many of the authors who wrote about the Lebanese outbreaks have recommended HIV vaccination, we know that in Lebanon we had the HIV vaccine. We had mostly the Havrix vaccine, which is a mono vaccine that should be given in 2 doses 6 months apart, or it can be distributed even further, 6 or 18 months apart. It should be given to children. It can be given to adults at risk, and we are giving them sometimes to people who have been exposed to the disease or pre-exposure prevention. Since the incubation period is usually between 2 to 4 weeks, we can still have some protective activity given the disease, either pre-exposure or even post-exposure, to give the vaccine pre or post-exposure, or even we can give it to our population. Unfortunately, when the initial recommendation came to give the vaccine to the Lebanese population, make it a universal vaccine for the Lebanese, the Ministry of Public Health then, and with a lot of meetings with experts, we were involved with this meeting, preferred to put more investment in the WASH sector, in the hygiene and sanitation, rather than the vaccination, since there were other and still other priorities for other vaccines in Lebanon among the children and among the adults. So this is why the Lebanese health authorities moved towards more investment in WASH with the help of the UNICEF. We had the twin Rex, which was available in Lebanon. I don't know if it's still available. It can cover for both hepatitis A and hepatitis B vaccine. There are others, third live attenuated vaccine. It is given in China mostly, yet although it is very protective and have very long immunity, yet mutation shifts and subsequent infection will probably are major downsides of this vaccine. So if you look at the burden of HIV in Lebanon, we know that the duration of systemic illness is larger and more severe and manifests more in adolescent and older adults and adults. So longer illness can extend up to 2 weeks, sometimes even more. It is associated with more complication. So if we take this year alone, if we look at the population between 20 and 60, not above 60 because we have cases, and not below 20, we know that there are at least 600 cases reported. So those people will probably have had severe symptomatic illness, had significant abstention from work, had significant morbidity, and they really had suffered from this illness. We know that we have a lot of older children, as I said before, because around 1,200 cases were above 10 years of age. And given the fact that the disease can be underreported because many people will not probably seek medical advice or do serological testing to report, then we probably are witnessing even a further increase in the burden. The response to the first outbreak was WASH. The response to the second outbreak is not yet formulated. We know that we need urgently to invest in our WASH infrastructure, water, sanitation, hygiene, and so on, because not only because hepatitis A, but because of cholera, because of other diseases. And this is really very difficult, especially in we are living in the times of war. We expect further destruction. We expect further displacement. People are talking about 500,000 displaced people to various parts of Lebanon. So this will be an extra burden. And this is why the response to the second outbreak will not yet be formulated soon. And we have to monitor these outbreaks and to see the effect of the Israeli aggression and war against Lebanon, where it is going to lead. So we are really living in a challenging scenario and a challenging vicious cycle where we really need to invest in our sanitary infrastructure with the help of international organization, but we are still lagging behind in sustaining the system, in providing it with enough electricity, in providing what you call adequate and safe supplies of water for human use and animal use and irrigation and so on. We are probably living under more severe poverty due to the extended political crisis and the further repeated wars and aggression against the country. We are seeing more displaced people. We're witnessing more destruction. I can tell you firsthand, I'm dealing with this. 50% of the people who are displaced have no facilities for washing, have no facilities for hygiene, have no facilities for toilets facilities, and they don't even have beds to sleep, even in what you call hosting places. We have, unfortunately, a failed state that will rely more and more on aid that is becoming more and more scarce due to several factors. The aid is becoming even less and less aid coming to Lebanon. We have the refugee problem that will probably stay for us with some time. And this is why probably later on, if we have a meeting about hepatitis A in the coming few months or few years, we are going to witness further dynamic change in the epidemiology of the virus. So the challenge is going on. We don't have enough money and enough support resources for our WASH, and we don't have enough resources to introduce hepatitis A vaccine for all. Thank you.
Thank you, Dr. Bizri, for